I'm Rohit Gosain, a community medical oncologist, and I have Dr. Raji Shameem from Orlando Health. Raji, thanks so much for joining me.
Thanks for having me.
Thank you. With regards to pancreatic adenocarcinoma, in metastatic space, it is important to check that germline testing as well as NGS. Now, if a patient is negative for that, how are you deciding on the current treatment option where you have the option of NALIRIFOX or modified FOLFIRINOX and even gem-nab-paclitaxel?
I think for a patient without any actionable biomarker abnormalities, which is actually the majority of our metastatic pancreatic cancer patients, the decision of your frontline regimen is very important. Acknowledging this is an aggressive disease and many patients do not see second-line therapy. So a lot of times I think pick your best option first. We have options that are listed in the NCCN guidelines. It is my practice, if I have a patient who has adequate performance status, able to tolerate multiple chemo drugs, I will pick a regimen like NALIRIFOX. And, modified FOLFIRINOX remains an option for patients as well as gem-Abraxane, but I want to highlight that NALIRIFOX has been evaluated in a phase 3 global trial setting compared to gem-Abraxane. And gem-Abraxane at standard dosing in the IMPACT trial, 3 weeks on, 1 week off. And I'm sure you would agree, many patients in the community, they don't get that type of dosing. We give every 2 weeks, we have our own way of dose reduction.
Or even week on, week off.
Exactly. But in that trial, they showed survival benefit, right? And one of the most important things is that there were clear-cut protocol recommendations of when to dose reduce and how to dose reduce. And I say that FOLFIRINOX, when it first came, was from the Prodigy Accord trials, right? Multi-center, single country trial, French trial. And, that led to modified FOLFIRINOX, but modified FOLFIRINOX might be different. Your modified FOLFIRINOX might be different from mine, institution, even in the same clinic, right? I feel that NALIRIFOX, it has a standard regimen. It gives me comfort when I make that decision. And many patients, when you want to dose reduce, they're apprehensive. Will that compromise efficacy? I typically quote clinical trial data that approximately 52% of patients might require dose reduction of maybe liposomal irinotecan, but there still was a benefit, right? So that gives me comfort and gives me confidence in prescribing that regimen.
Thanks for covering that. An important thing that you mentioned, that when you are dose modifying this agent, you're not seeing any differences in efficacy itself. Now, tying in some of the clinical pearls with regards to irinotecan conventional and nanoliposomal, if you could just go into granular detail some of the side effects that you see with either of them.
Yeah, I would say there are more similarities than differences, right? Yes, you can see diarrhea with conventional irinotecan as well as liposomal irinotecan, but I always say that you always want to assess the patient at baseline, right? Many patients with metastatic pancreatic cancer have malabsorption, right? And if you don't ask them their baseline, how do you really assess the severity of their diarrhea?
Right.
So even more important than the specific drug is that patient and what is their baseline diarrhea.
Yep.
And I feel that whatever drug it is, prompt recognition, utilization of antidiarrheals, they will prevent severity no matter what the type of drug is. But once again, like NALIRIFOX in phase 3 global randomized trial setting, I have a trial that told me how to dose reduce and when to dose reduce.
Indeed. And with regards to UGT1A1, are you testing that upfront? And also, do we have to worry about that with nanoliposomal irinotecan?
That's a great question. My institution mandates that we check these type of testing, including DPD, just to assess risk for toxicity. But it should be noted for NALIRIFOX, regardless of if there's any metabolism issue, the dose is the same. For UGT1A1, the dose remains 50 milligrams per meter squared. And that's really helpful. Sometimes you want to start the patient as soon as possible. Do you really want to wait for the results? That dose does not have to change. It remains 50 milligrams per meter squared, which is different for a later line using NALIRI, where the dose might have to be dose reduced from 70 to 50 milligrams per meter squared.
Perfect. Well, thank you so much, Raji, to cover all this, what we have at pancreatic adenocarcinoma when we don't have any NGS or germline testing available.
Thank you. I appreciate it.